Welcome to the CodeCast podcast. Real-world insights for your daily medical coding and billing processes. And now, here's your host, Terry Fletcher.
Hello, everyone, and welcome to the CodeCast podcast today. My name is Terry Fletcher. So I wanted to bring another element into the CodeCast with regard to the E&M services. And I think it's important because this actually is in the number and complexity of problems addressed, and it comes up all the time. And it's acute uncomplicated versus acute complicated, and what we're talking about from a coding perspective. Now, in the low medical decision-making, first element, remember you have to meet 2 out of 3, but the first element on number and complexity of problems addressed, and this is from the 2021 guidelines, again updated in 2023. Under low, it has 1 acute uncomplicated illness or injury, and then in the moderate, it has 1 acute complicated injury. And you can also add illness to that because the AMA does in their detailed description. I know sometimes some people have a pushback on that because they're only looking at the grid that AMA put out in 2020 for the revisions January 1st, 2021. And you can't take everything verbatim. You have to keep digging. It would be like trying to code from an operative report from the header and not looking at report detail. You have to code from the detail. So while the 2021 E&M guidelines, again with 2023 revisions, did provide us with more clarification, there's still sections that are subjective and rely heavily on the detail by the treating practitioner's documentation. And with EMRs and providers continuing to use cut and paste, pull forward, and all of that, we're not being able to really find, and I'm saying from a coding and auditing perspective, that complicated situation, if you will. And so sometimes things start off as an acute uncomplicated. So a lot of people will, reference this as not documented, not done. But when I do an audit or review, I'm often asked why a particular symptom or diagnosis was not determined to be complicated. And I get this all the time from providers. And this is due to the fact that every note stands alone. And as an auditor reviewer, whether coding or auditing, we cannot make any clinical assumptions about a patient. That's why we also have queries if it's necessary, but typically we do that in the inpatient setting if we're trying to figure out, for example, with sepsis on the intake or did it happen in the hospital. But we're not going to say, well, I think you should have said this, so I'm going to query. We don't do it that way. But I don't like that statement. It's not documented, not done. And actually, I'm also looking at an article recently posted by Stephanie Allard, a compliance article from February 27th. She's a colleague of mine. We work together on auditing, work together for the Compliance Guy podcast as well. And I really liked some of the things she put in her article. So I'm using that as a tool. And so shout out to Stephanie. Plus, I'm also I'm referencing it, I should, and adding my 2 cents as well, because I was going to talk about this and add some insight as well. But I'm a firm believer that if we did find something that was not documented during an audit, and I'm finding it consistently, and the reason I say we find it not documented, sometimes it's hard to find something that isn't documented until then you get to the assessment and plan and the risk of complication, and you're like, why did you do that if I didn't see it in the first problem addressed? And so sometimes we'll have a discussion with the treating practitioner to figure out what exactly was done. And when we take that approach, we're able to have really productive conversations sometimes to determine first if the described scenario does actually meet moderate risk of the presenting problem, and then second, to continue the discussion in relationship to the documentation requirements. Now, this is not at all to encourage physicians or to add documentation to upcode. I don't ever want to do that. And I get that question a lot. Well, how can I make this a level 5? Do not ask me that question. You should be asking me, well, here's my patient scenario. Where do I go from here? And what does this sound like? So as an auditor, it's extremely important to remember that we cannot, as auditors or reviewers, apply a level of risk based on a specific symptom, complaint, age of the patient, or just listing a condition or diagnosis. So, for example, not every chest pain, not every abdominal pain, not every fracture automatically supports moderate risk. And I see that all the time where they say hypertension and diabetes stable, and they think all of a sudden that's moderate risk. Not necessarily. And also from the I guess to say this, the clinical perspective that it could be if it's something you're managing, but I'm now finding that there's providers that just list it to list it, and it has no impact on their treatment or what they do. They're just listing it to list it because they know it's somewhere in the patient record. And so that again does not afford you that moderate if it's not something that impacts what you're doing. So it's extremely important to remember the fact that we can't apply something and that not everything is automatically moderate risk. But from a coding and auditing perspective, when documentation is supporting a presenting problem as acute uncomplicated, what we're looking at is that it is due to the note showing that the illness or injury is expected to be resolved and there is an expected course of treatment. There is little to no risk of morbidity with treatment, and full recovery without functional impairment is expected. Think about COVID now and COVID at the height of the pandemic, where we had people with chronic conditions, with COPD, with respiratory, issues, and they were running into some trouble because of the complicated, symptoms, or I should say complicated conditions they had in addition to that first COVID diagnosis. But now, 5 years later, we find that presenting at COVID, young patient, no comorbidities, it tends to be low because they give them, Paxlovid and say, be on your way, PRN. And so this is where you have to notice the difference. Now, a more complicated injury or illness is supported when the note shows the factors that make the treatment more challenging. It's not just saying it either. It drives me crazy, and I know some of my fellow auditors drives them crazy too when we see doctors saying this is an acute illness or an acute complicated injury. Well, what makes it that way? Just saying it isn't enough. An acute complicated condition is referring to one that is more serious and involves potential complications, significant risk of morbidity, and often requires more extensive testing, evaluation, and/or treatment. So as you can imagine, that would need to be reflected through free texted documentation, not just, click and point method or pull through from the last visit. When the provider chooses to document with a point and click method that only pulls in pre-populated information without updates, and it's impossible for an auditor to know the complexity issues unless they are non-compliantly choosing to assume the risk. And you can't do that. I'm talking to my auditor audience out there as well, or even my coders out there that look at what's being coded. So whether working with encounters from a coding or auditing perspective, it is important that we do not read between the lines for our providers. Do not reward being lazy about documentation. It's not going to do them any favors when the documentation has to be upheld to scrutiny externally, either by an audit by a payer or has to be defended if you're dealing with UPICs. And that's another reason why I think external audits are so important. And I have a lot of clients right now that are using us as external auditors on an ongoing basis, not just doing one and then saying, see you in 5 years. So something to consider. And that's not to promote business for me, well, maybe a little bit, but just basically letting you know that we are here if you need that. But there's always a question that comes up too, and it says, Terry, why do you say complicated acute injury or illness? Because again, I don't see that on the grid. It just says illness. Well, when you look at the AMA explanation for acute illness with systemic symptoms and the undiagnosed problem with uncertain prognosis, again, remember the detail. You have to go to all the detail. It points to the complexity of the patient and even goes as far to state that a more complicated patient would have a high risk of morbidity without treatment. So from a provider education standpoint, this is largely misunderstood with documentation, often lacking detail related to thought process, severity of the patient, and or they're concerned. And all of these things are needed to show complexity. We cannot make that leap. Think about the patient that is diabetic. And basically that there's a potential that patient would be slower to heal under certain circumstances. Well, that main point on that complexity can't just be assumed. I mean, I'm a former nurse. I can't just assume that, even though I know that rule. The providers I educate, I make sure you say, give me that link. Show me where your thought process is, where you didn't order a statin, or you're concerned about this kind of treatment because the patient's diabetic or has this high risk medication, or they're on a blood thinner, so you had to switch directions. and show me why you ordered what you did, why you changed directions in your treatment, why you did. And I do find that the provider's input is invaluable, as it really helps to bridge the gap to know what they're doing versus what they actually put in their notes, and to educate on that fact. So it's also a good exercise to show them how subjective the presenting problems can be without any clarification. Not only can, we make that leap, but we have to have more information to be able to get a clear total profile picture of that patient for today's encounter. There's a television show out there, I think I've mentioned it before on my podcast. It's called Numbers. And it was from, I think, 2006 to 2011, somewhere around there. Look it up. It's on Amazon. It's a great show. But I remember, Charlie, one of the mathematicians on there, and it's about FBI. When he does his calculations through numbers, he's like, the more information I have, the better informed I am, where I can make a decision. And, I always apply this to what I'm doing too. We can make a better decision with more information. We can throw out the stuff that, is just minutia and doesn't matter, but we need to find that link, that thought process, and why, today you need that information and how it impacts that patient on the risk factor. Remember, we've got 3 elements in the E&M services. We've got number and complexity of problems addressed and the risk of those. We've got amount and or complexity of data to be reviewed and analyzed. And then we have the risk of complications and or morbidity or mortality for patient management under the assessment and plan. And you have to meet 2 out of 3 of those to be able to get your level of service. So if you have moderate, let's say you do have 2+ stable chronic illnesses, they're at goal, you actually explained yourself, you didn't just list them. You didn't have any data today, maybe you had 1 lab, so that would be straightforward. And then you basically told the patient, you know what, continue meds, we'll see you in a year. That's low. So what did you meet? Well, you have moderate on the first one, you have straightforward on the second one, and you've got low on the third one. That's low. That's a 99213. But let's say you actually went a little bit more detail on, did the patient, are they at goal with their medications? Are you going to adjust medications? Are you concerned about any interactions? Do they have an upcoming dental surgery that you have to make an adjustment? Are you watching anything? Did they get another medication from another provider that they had a question about interactions? Are you concerned with the patient maybe that is getting chemo or radiation, or did they have a question about something they saw on TV that could be a problem? Or, recently I had a conversation with an oncologist, and he's like, oh my gosh, I forgot to talk to, or not forgot, that's a bad way to put it. He said, we didn't have a conversation because it really wasn't something I thought this patient was party to as far as supplements by getting radiation or chemo. That's terrible. The interactions are terrible. And so he's like, and then all of a sudden we have, an allergy, we have a reaction to some of the radiation. And I was like, wait, are you taking this supplement? He's like, oh my gosh, okay, you need to stop doing that. And it became now this really intense, complex toxicity issue patient. And so even when you think, talking to the providers that it may be a small thing, you really have to document it because it could impact their short and long-term care. And it's something that you can't make that leap. Remember, it has to be both, more than just saying, great, you're good. Patient return is needed means you don't think that you need to have input on their medical decision-making. PRN says, see ya, have a good life, and call me if you need me. So that it's hard to get moderate or anything above low with that. So just keep that in mind, because I think this is an important topic, because those are 2 of the discussions, I should say, or points that happen quite a bit when we talk about, acute uncomplicated versus acute complicated, from a coding perspective and an auditing perspective. And when you leap from a level 3 to a level 4, you better be able to back it up and support it. Otherwise, you could find yourself in trouble or sending back some refunds. Okay, so today, my personal tidbit, I actually get to go to Napa in a couple of weeks with my daughter and her husband and my sister-in-law and my older brother. He's not older than me, but I do like to say that phrase, older brother. I'm the oldest, so there you go. But we're excited about it. We're there for 3 days, and we try to hit 6 wineries and a couple of nice restaurants, and we're anticipating good weather. And we're there on St. Patrick's Day too, so that'll be really fun. So I'm excited about that. But I'll try to give you some more information when we return from that. But anyway, I hope everyone, now that we're getting into spring, we're going to be turning our clocks forward, so we're going to get some extra sunlight at the end of the day. Everyone is excited for a change in the weather. So make it a great rest of your week. Make it a great day. And thank you for listening to the CodeCast podcast.
For more information on medical coding, billing, auditing, and compliance, including how to hire Terry, follow Terry on Twitter @TerryCoder1 or visit her website at www.terryfletcher.net. Podcast producer Joe Kuzma. Music producer Dassassin Music.